that's somewhere I wanted to go, because you brought up something I think was really, really important in the book. Was this isn't always, I mean, we think cancer and we think, oh my God, I got to do something. But sometimes just actively monitoring yourself is actually the best thing to do, because of the downside risks that some of the surgeries could have on us. Can you talk a little bit about that? When would we know, okay, this is something we definitely need to deal with now, versus we can comfortably sit back and know, yes, I've got the cancer, but it's not going to harm me in the next 5, 10, maybe even 15 years.
You're talking about the advice of active surveillance. So let's say a man has an elevated PSA and he gets a biopsy, and a biopsy has shades of gray. It's not just black and white. There's shades of gray, and there are various scores that the pathologist will give. And so there's very almost normal cells that are cancer, called well differentiated cells. And then there are highly malignant cells. And if you have well differentiated cells and the PSA is mildly elevated, between 4 and 10, mildly elevated, active surveillance is definitely appropriate. But that means coming back to the doctor every 4 to 6 months and getting a PSA. And if it jumps up significantly, and then you might have to have another biopsy. And if that shows more aggressive cancer, then you might have to proceed to definitive treatment. And we can talk about the side effects of treatment. And the treatment usually, if the disease is confined to the prostate, no spread outside the prostate, the two options, common options, are surgical removal of the whole prostate gland or radiation therapy. Both of these have adverse events or side effects, and it's often these side effects that discourage men from having the surgery or the radiation. With the surgery, they can it'll affect their erections, their ability to achieve and maintain an erection is diminished, and they can have a problem of loss of urine, which is a terrible situation that it can ruin a man's quality of life, and he has to wear a diaper or he has to have additional surgery because of the loss of urine. It's embarrassing. The man often becomes reclusive. They can become depressed. It's a terrible situation for a man, but he needs to know that if he's going to have the surgery. It doesn't occur with radiation, but they can also have a problem of impotence. So let's just say a man 60 years of age, he's sexually active, he has a very low malignancy, PSAs between 4 and 10. Active surveillance, if he's committed to close follow-up, is definitely appropriate. Now take a man 70 years of age, and if he has comorbid conditions, let's say he's diabetic, heart disease, high blood pressure, and has got other medical problems. He has COPD, chronic obstructive pulmonary disease. He has shortness of breath. He probably isn't going to live 5 years with all those morbid conditions. In that situation, I wouldn't recommend that he have surgery, because the quality of life that he will have afterwards could be severely affected. He's already having problems. He's already short of breath. He's already taking 5 to 7 pills a day. Okay. So that man would not be, in my opinion, would not be a candidate for definitive treatment. On the horizon, Alan, are new treatments called focal therapy. Instead of treating the whole gland with radiation or removing the whole gland, they can just go in and do an equivalent as what's called a lumpectomy in a woman with breast cancer. Instead of removing the whole breast, there are certain situations where you just remove the lump. Well, this is the equivalent, called, the nickname for it is a male lumpectomy. That's on the horizon, and there are studies being conducted now and following these men, and it looks very promising that you don't, if it's caught early enough, listen, if it occupies the whole gland, well, then you remove it. But if it occupies one little tiny area and they can localize that, and they can focus on that particular area and destroy that cancer in the prostate, I think that's going to be the way to go. And that's going to be, I think, go mainstream in a very short period of time. Studies are being conducted now for focal therapy.